I'd like to allow our panelists here to give a very brief introduction to themselves and their companies. And really what I'd like to do here for the rest of the time is have an open dialogue and really get questions from the audience, questions amongst themselves if possible, and really try and get an idea of, what is it like in the real world? What are practices facing? What are radiologists facing? What are departments facing throughout this? So we'll start right here with Joel.
Mark.
Oh, sorry, Mark.
I'm Mark Migagosian. My company's RadMaps, and at our core, we're a radiology term mapping company. We map and normalize radiology terminology and DICOM data. Our current project is with the ACR Dose Index Registry. As you may know, there's hundreds of sites that send thousands of varyingly named exams to the ACR. As a consequence, we need to categorize those into logical groupings, and that's what RadMaps does. We create those groupings, for example, CT scan of the abdomen or CT angiogram of the aorta, whatever groupings might be relevant from a radiation dose standpoint. And in creating those groupings, we use a standard from the RADLEX ontology and also map to the RSNA RADLEX orderable standard.
Great, thanks. Mike?
Yeah, I'm Mike Batten. I'm the Chief Operating Officer for PAX Health, and we manufacture the dose monitor product that is here. And I want to say congratulations to Mark. This is Mark's first trade show as a vendor. So it's always an enlightening experience to see somebody new at this game, and it's very unique to see them out there with a new, and it's a very interesting product, actually, so I encourage you to come take a look at his product. We manufacture Dose Monitor, which is an automated dose tracking and management tool that absorbs the dose data from the DICOM header information or direct from the modality, and has been a proud sponsor of the ACR DIR and in helping customers obtain a pathway to getting their data down to the registry.
Greg?
Hi, I'm Greg Couch. I'm the founder of Radiometrics. We produce a product called Exposure. We think of our product as more of a QA/QC tool. Dose aggregation and tracking and patient dose estimation is a big part of that, but it's definitely not the only part. And in fact, that's really where we spend a lot of our time now. Is, we see a shift in terms of just focusing on, what was the dose associated with that exam, to, why does this protocol differ from what I thought I set up, right? And that's a big part of what we're spending our time.
Great. Well, thanks for the introductions. And right now, I'd actually like to open it up to questions. So we'll pass the microphone around. Before then, I actually have a couple of questions that I'll ask first to get things started. What are some of the major IT challenges that you face when you're trying to install radiation dose monitoring software or any other type of software related to dose or the dose index registry at particular sites?
Well, I think I'll throw out the bigger challenges is right now just order of priority, right? So if you look at, situation in California where there's legislation and compliance requirements, one of the biggest challenges we had is, within radiology it was seen as a priority. Within the organization that was maybe facing a big EMR implementation, it wasn't seen as a big priority, right? So the sort of getting the rest of the organization to understand how important it is a big part of it.
Yeah, I'll echo that as Epic takes over the world and everybody is doing an Epic implementation. Very tough to get IT time slice to get even smaller projects like this done. And I think it's one of those organizational initiatives that we try to drive from the top down and really get buy-in from senior leadership in the house that says, this is something we want to do, we're committed to doing, and we'll give you the resources to do that. It's something, especially as Greg mentioned, California, that just kind of crept up on them, and as of July 1, 2012, they need to have a reporting solution in place. Many of our California customers pushed it as hard as they could and have pushed it back, and I've heard many comments from potential customers that said they'll have to drag me in there to do it, or come and get me, or things like that. But again, I think it's all about priorities. Exactly right, what Greg said, and internal to the house, and where the dollars are available.
So,
yeah. Actually, any questions so far from the audience? So, how do your systems work with the ACR Dose Index Registry, and what value do you provide?
Mark, go ahead.
Well, what value we provide is really, again, the categorization, the relevant logical categorization of studies. Our company, yes, we do map to the RADLEX ontology and the RADLEX orderables, but really, and that may be the standard of the future, though at this point, that's an incomplete standard, and so we need to be flexible and decide what that standard will be, and companies need to map to whatever standard is out there in the near future.
And so, I mean, for Mike and Greg, what are the advantages really of using a commercial solution over just participating in the Dose Index Registry, or and vice versa? If you're using a system like yours, what's the advantage really of participating in the registry?
Yeah, so just for Greg and I both, our tools allow the automated collection of that data and submission to the registry. So it really creates a pathway for the end user, the customer, to not have to get involved in that conversation if they don't absolutely want to or need to. One of the early components of the registry piece was having to install a separate facility-side server that was configured via assistance from the ACR, and configured via a lot of phone calls back and forth with various IT folks. That we had heard some feedback was somewhat challenging. I think there's some conversation on that coming up tomorrow about how to improve on that process and do that. I think that the commercial advantage is that we are able to take that whole concept, including the client-side server that sits at the hospital. In our case, we wrap it up on the same box that is available for our application, do all the processing in the background, and it's essentially hands-off for the customer.
So I would add to that, just the whole, you mentioned the whole idea of being able to provide tools that map orderables to the RADLEX terminology. There's sort of one step beyond that, because we all know that what gets ordered isn't necessarily what gets done, and just simply submitting data based on that doesn't really lend itself to sort of a reliable data source. So we give the option of being able to look at that and compare it to the protocol, and actually do it based on the actual protocol itself. And for example, if there's something that was ordered as a head and it ends up including a C-spine and a chest and turns into a full trauma study before you know it, that doesn't get submitted to the ACR under the label as a CT head.
Question from the...
Information in a form that is meaningful to them?
Very interesting question, I'd say, because I think we're all wondering what the consumer really wants and what the value is to the consumer. Just as a purely editorial comment, I hear every day that the dose data that's produced by the modality is useless, means nothing, and has no real value in the community. Now, I don't know if this room agrees or disagrees with that, but I've heard it in a lot of different contexts. Also in context of it's inappropriate to provide this to the consumer, the end consumer, the patient. California is currently doing that now, where they are required to put the CTDI vol and the DLP on every CT exam that goes out the door. But again, this has no context around it, and I always challenge my customers or potential customers to provide some type of conversational metric around what those numbers mean. Is there a reference range? Are you in, out of the range? What does the relative risk mean to you as a consumer of why you're getting this study? Is the risk benefit of getting this study versus the potential for the disease that you have adequate enough to continue on with the study? So a lot of good conversation. I don't think I have an answer for it.
So, I mean, I think it falls into two categories. One, are you going to try and communicate to the patient some form of risk, right? Which at best is kind of a hand-waving argument and perhaps, you know, not appropriate. That's kind of the customer's call. But to me, if I look at the situation in California, the legislation just sort of said stick these values in the report, right? Which we ultimately know is going to fall into the patient's hands. The value of what we're trying to bring is that we put it into a context, which is allow them to report a range that's specific to that protocol so that it is actually meaningful to them, or translate it, add something else which can be, you know, the problem with reporting CTDI and DLP, right, is it's not consistent across scanners, protocols, practices. So you get strange things occurring, and people, you know, if you leave it to someone to interpret that, then there will be a problem. Whereas if you actually have an automated way of saying, let's convert this to something that is more meaningful on a single scale, right? I mean, the confusion that we always see is people see CTDIs and DLPs and try to interpret them as if they're all on the same scale, where they don't follow that. So it's up to us to provide some mechanism to put that in an appropriate context. And that's what we do.
Yeah, at Society of Computed Body Tomography earlier this week in Boston, some of us here were in a roundtable discussion with Dr. Frusch, and there were also audience response questions to the radiologists in the audience, about 300. And it seemed like the responses were that most radiologists would not want to put in the dose for the patient. I know I wouldn't myself, because what information, as you've mentioned, what good does it do to know what your CTDI is or DLP? I mean, I wouldn't have known a couple of years ago myself. And I think what our conclusion was, at least what I got out of it and supported my public health background, is from a public health perspective, I think what the consumer would want would be that range, or what is your institution doing? Oh, I'm participating in Near-Deer. We are looking at trends. We're using Radiance because it's there. We can see where our peaks are, and oh, look at that, my so-and-so scanner is doing this. So I would think that's what the consumer wants, but I think what ACR or somebody should do is have a panel so we can kind of internally, not police ourselves, but watch, which is what Near-Deer is doing, I believe. Rather than being told by California. I mean, that was just a gut reaction. Hey, go and report dose, and that's an action that I don't think is appropriate myself. But that's just me.
Ultimately, it seems to me, I don't object to providing consumers the value, the values of the doses, but I would think ultimately the highest value is to the physician who's sitting there ordering it, and that he or she needs feedback on dosages to know how much doses this patient received, lifetime dose, whatever, given all the exams in their medical record, and they can make intelligent decisions with the patient to decide whether that's the most appropriate study or not.
I'm glad you mentioned that, because that's what we started doing ourselves. We're using Radiance to pick out the high exams. It does end up being my customers that are urologic, triple phase, carcinoids, so they know, especially if they're larger patients, they're going to be of the higher dose. But because I'm sending them letters, I mean, I'm not getting this from any guidance except ourselves saying, hey, let's draw 50 millisieverts estimated as a level. Everyone above that level gets a letter through a secure encrypted email. Half of them don't read it, they just see, oh, I got another one of these. But at the same time, a couple weeks ago, I was asked, hey, why don't you come and give us a talk on how we can lower dose? And there I talked about our iterative and lower KVP options and this kind of thing. So that is successful for us. So I agree that I think it's the ordering providers. In addition to cost financially, what is the radiation cost?
So are you doing any education with the referring physicians in specific subspecialties such
Yes.
as ENT or Uro, GYN, that are high-frequency ordering physicians about effects of dose and about relative risk to patients?
Well, I'm in a different kind of practice. It's all research-based. But yes, the folks that are getting the more letters are saying, some of them had even asked me, should I be informing the patient? I said, I don't think we're ready for that. But I gave them educationals, and they are now looking into iterative and some other ways of lowering dose. Some of them I can't go with my lower KVP option because we're doing Hounsfield units of tumors that I want to be consistent with. So I said, okay, don't do the KVP thing doing I'm doing with pediatric chest, because that's an easy low-hanging fruit. That I cut doses in half right away with that. But with some of the stuff with where I'm looking at the enhancement of these tumors, I don't want to be changing KV or applying care KV when I don't know what the KV is doing to the Hounsfield units we're trying to compare over serial exams.
And do you see any evidence of providers decreasing the number of studies that they're ordering?
Yes, yeah. Not because of the letters, but because I think mostly because of the SEA 47 and our heightened awareness and our newsletters to the providers, our intranet, and just telling them sometimes, hey, if you can measure the tumors on the PET CT, you know, I'm going from my Biograph 128 to my so-and-so 4-slice. You know, what am I doing when I can see the tumors on the CT non-diagnostic? I don't give the report, but I think that's something we have to get over eventually too, but I don't want to open that can of worms.
But to some extent, this discussion about whether it's appropriate to provide the dose information to the patient, that ship has sailed, right? I mean, whether it's through the media reports, the legislation in California, the marketing that some facilities are doing, even right down to the CT manufacturers. I mean, you see ads for, you know, directed to the general population on how low dose my CT scanner is, right? We're beyond that, right? It's now going to be recovering from that situation, right? And having, I think that the thing that we kind of struggle with in terms of credibility is not having put the processes in place to actively monitor what we were doing from a protocol perspective, that we're now kind of faced with this situation to kind of dial it back.
Question over here.
So I was wondering, there's a lot of suggested rules and guidance that's coming out about protocol review. So obviously you guys are creating a database that's doing the dose mining. Is there some features in there that gets into the image quality side of it, so they're half the story, that can kind of enable and facilitate that protocol review? And I think facilities like ours, where you've got 120 plus protocols, that's a huge challenge. And many states are trying to legislate this on an annual basis. So do you guys have any tools for something like that?
Go ahead.
Yeah, so definitely, I think you've kind of touched on what's important. Sort of trying to optimize your protocols just by looking at dose is a bit of a problem, right? Because if you end up repeating exams because you've decreased the dose to the point the image quality requires that you end up doing that, you've defeated the purpose. So we've definitely started building that concept into our system, and the ability to look at, you know, you have to come up with surrogate measures for image quality, because this is a challenge, particularly when you're trying to work across multiple scanners, and then you add things like iterative reconstruction and model-based reconstruction in there. But the good thing is, even with crude tools for doing image quality estimates, you can actually get some pretty interesting feedback. So we've been working on that.
Yeah, our side as well, we've been able to capture variance in protocol. So if a protocol's changed or a protocol's different from what it was previously, map that to the dose data and see if there is a variance in there as well. It's fairly interesting. We did a large study recently that had about 8,000 exams in it of a specific CT head without, and mapped it across multiple different facilities and watched as the protocols were changed. And the graph was very interesting. So it wasn't a straight line graph. It was a very wavy graph that had peaks and troughs all over it as they continued to look at image quality, which again is subjective. So very difficult to measure adequate image quality across multiple readers and multiple facilities. But you could clearly see the trend of, let's turn the volume up, let's turn the volume down, and see what's comfortable. So yes, in the short answer.
One more question here. I mean, how do you plan to deal with the challenges? You know, as you know, whether we like it or not, you know, as patients are getting access to their dose information, you know, as they go from facility to facility, you know, we have to deal with image sharing to be able to handle the fact that patients get imaged in multiple locations. You know, is there a, you know, how do you plan to deal with, you know, a patient's cumulative dose if it tracks across multiple institutions and you know, which may have different vendors or not only for scanners but also for dose management and things like that? Do you have any thoughts on how that's going to be handled?
Well, I think that's an extremely difficult problem. I'm a practicing radiologist, and a partial solution at our institution was to try to centralize the storage of all the images for the region, and so that we would have that wasn't the primary purpose. Mm-hmm. Radiation dose wasn't the primary purpose. It was patient care from an imaging standpoint, but that has provided us with perhaps a little bit better handle on really what radiation dose patients are having in our region. So,
I would state that that's one of the most frustrating conversations for many of our customers, is not being able to track effective geographic conversations about that. We've seen some great work with some of the RIOs in some various locations throughout the U.S. Bellingham, Washington's a good example of a strong RIO in a very defined community with a northern border that's a different country and mountain ranges around it that really contains the population, and they've done very well at dentist's office and any kind of a medical care provider creating that single patient information component. Other than that, we see it frequently for many of our customers that are even within the same health system and see multiple MRNs created for patients that have not been normalized across an EMPI or other state. Very difficult, very frustrating, and I think that's going to be a focus. I hope it's a national focus with whoever's in Pennsylvania Avenue next. That gives us that national medical record number across our continuum, so we can, you know, provide not just this but other components.
Yeah, I'd say I wish them a lot of luck in that endeavor. I mean, we've had some interesting experience with outside of this country where we actually have a national repository, and you know, surprisingly, the attention is not on tracking cumulative dose for the patient at all. It's ensuring standards across the hospitals that make up the country. And so, you know, I think it's a nice to have, but I don't even know that we're in a position to do anything useful with that information. I think we're kind of a long way away from being able to look at a cumulative record for a patient and use it in any form of determining appropriateness, right? So if it's clinically necessary, based on, you know, a lot of these measures that we're talking about in the earlier discussions, does cumulative dose actually really enter into the equation? Is it going to change the balance of the equation? I'm not sure we can answer that at this point.
And I'd agree with Greg on that, and I think that having a national identifier, though, would create the ability to look at repeat studies, repeat exams.
You don't need a detailed dose calculation to tell you the patient's had too many CTs,
exactly.
right?
Exactly. So show me that lower back pain patient that's moving from hospital to hospital to hospital, or that kidney stone patient that is continuing to look for treatment alternatives in different locations. Those are the type of things that'll drive healthcare costs down.
That question in your answers, though, goes back to why I asked the question about patient focus before, because I think there are really two very different audiences here that perhaps your companies ultimately can address. One is the departments who are trying to get their operation to be correct, and that's the first level of this. But you're right, right now there's no interest because the patients don't have a mechanism other than I've had a lot of x-rays. But I do think that at some point the nature of the question will change, and patients who use a lot of radiology services become very focused and obsessed on those services. And they may be a target audience for this. And I suspect that your businesses may end up being linked to HIEs and image sharing businesses to try to provide an aggregated record for those patients as much as their providers who are ordering it. But I would agree that that's probably years down the road.
Yeah, I mean, we see that. I'll tell you what we see as a more immediate, patient-focused initiative. It's the typical thing where you end up with a pregnant patient that's scanned, right? And they end up waiting weeks for a physicist to do some sort of hand-waving argument as to what kind of dose they got, right? One of the values that I think we've been able to bring to the table is when that does happen, we can generate a report for them that they can hand to the patient right there and then to put their minds at ease, right? And I think that's much more valuable to the patient right now.
All right, any more questions? All right, well, I guess that's it. This concludes the first day of the, well, it actually concludes the Imaging Informatics Summit. Tomorrow is the Near Dear User Group Conference. I want to thank all of our industry partners for helping to sponsor this event, the ACR staff for helping to put everything together, and all the other speakers, again, for contributing their time and their expertise. Thank you.